This is Chapter 8 on joints and articulations. Joints, also known as articulations, are where two or more bones meet. So our joints allow our skeleton to have some mobility, allow us to move, as well as helps to hold the skeleton together. So these joints or articulations are going to physically attach the bones to one another. There's two ways that we can classify different types of joints. So the first way would be structural. So classified based on the structure of the joint itself. So what type of tissue or material is holding these bones and these joints together? So structural classification could include fibrous, cartilaginous, or synovial. Functional classification looks at what type of movement is allowed at that joint. A Synovial would be an immovable joint, so like the sutures of the skull. So this is technically a joint because we have two or more bones joined together or meeting, but it's not a movable joint, so it's a synarthrotic joint. Amphiarthrosis are slightly movable, so amphi kind of like amphibian, so it's kind of movable, kind of not. And diarthrosis are your freely movable joints. The structural classifications are a little bit more clear-cut, so we will just primarily focus on those. Fibrous joints are joints that are joined by dense fibrous connective tissue. They have no joint cavity, and most of them are going to be immovable or synarthrotic. There's three types of fibrous joints: sutures, like in the skull, syndesmosis, or gomphosis. Sutures are those rigid interlocking joints of the skull. So the plates of the skull have these wavy edges that kind of interlock like puzzle pieces to form these suture joints. So during childhood growth and development, they contain short connective tissue fibers that allow for expansion. So as the child's growing, their brain's developing, the skull can grow with it. But as we reach adulthood, these sutures will ossify and become immovable joints that join the skull as one complete unit. So similar to the closure of that epiphyseal plate in long bones. Syndesmosis are joints that are connected by ligaments or bands of this fibrous connective tissue. The length of the fibers can vary, so therefore the movement can vary. So the shorter the fibers, the less movement will be possible. So one example of this would be on the tibiofibular joint. So the joint of the two bones in the lower leg. Longer fibers offer a larger range of movement. So example would be the interosseous membrane between the radius and the ulna of the forearm. Gomphosis are peg and socket joints found only in the teeth. So where the teeth are going to join to the jawbone, the mandible. So our fibrous connection here with gomphosis joints is the periodontal ligament that holds the tooth in its socket. Cartilaginous joints are bones that are joined by cartilage. So remember we said we had three types of cartilage we looked at in the previous chapter: hyaline cartilage, elastic cartilage, and fibrocartilage. So cartilaginous joints are not highly movable, and they have no joint cavity. The two types of cartilaginous joints are Syncrondrosis and Symphysis joints. Syncondrosis are just a bar or plate of hyaline cartilage that's going to unite bones together. So again, whenever you see the root word chondro, we're talking about cartilage. So almost all of these syncondrosis joints are immovable or synarthrotic. So an example would be the epiphyseal plate where long bones grow in length. So that's technically a joint because we have some cartilage uniting this piece of bone to this piece of bone. So after the epiphyseal plate closure, once we reach adulthood, it's then referred to as a synostosis. Another example of synchondrosis joint would be the cartilage between the first rib and the manubrium, or this top section of the sternum or breastbone. Symphysis joints are united by fibrocartilage. So hyaline cartilage will also be present just as the articular cartilage on the surface of the bones, but the joint is held together by fibrocartilage. So these joints are very strong and amphiarthrotic or slightly movable. So examples include the intervertebral joints, so the plates of this fibrocartilage between the vertebrae. So remember we said fibrocartilage was good for shock absorption. We also have symphysis joints in the pubic symphysis. So we have this thick, rigid plate of fibrocartilage to help withstand our body weight while walking. Synovial joints are joints that are separated by fluid-filled cavities, so this allows them a wide range of motion. All synovial joints are diarthrotic or freely movable. It includes almost all of the limb joints. So pretty much when you think of a stereotypical joint in the body, you're thinking of a synovial joint. Synovial joints have 6 general features. So first is the articular cartilage. So we said the ends of the long bones are covered with this thin layer of hyaline cartilage just to prevent crushing and reduce friction on the bone ends. The joint or synovial cavity is a small fluid-filled space that is only found in the synovial joint. So this is what helps contribute to that wide, free range of motion. The articular or joint capsule contains 2 layers. So you have an external fibrous layer composed of that dense connective tissue just to help add some support to the joint, and an inner synovial membrane shown here lining the cavity in green. So this is a loose connective tissue that's going to produce our synovial fluid in the cavity. Synovial fluid is a viscous or thick, slimy type of fluid made of plasma and hyaluronic acid. So it has kind of an egg white consistency. So it functions to lubricate this joint, these bone ends, and reduce any friction. It also contains some phagocytic cells or eating cells to remove any microbes or debris. So we keep a clean, sterile joint cavity to reduce any inflammation or irritation to the membranes and the joint. Synovial joints also will contain different types of reinforcing ligaments just to add more structure and support to the joint. And finally, synovial joints contain nerves and blood vessels. So we have nerves to detect and monitor our joint position and how much it's being stretched, as well as pain. Capillaries in the blood vessels will supply the fluid from the blood plasma to supply the synovial fluid. Some other features we may find in synovial joints include fatty pads, just for some extra cushioning between the bone layers or the capsule. We also may see articular discs or menisci or meniscus in some joints like the knee. So this is just some fibrocartilage padding. So remember, fibrocartilage was very good for shock absorption, weight, and compressive forces. So we have these fibrocartilage pads or these menisci in the knee joint just to help improve the fit of the bone ends, to help it fit more nicely and neatly and stabilize the joint and reduce wear and tear on the bones. Bursae and tendon sheaths are bags or sacs, if you will, of synovial fluid that act kind of like lubricating ball bearings. So while they're not technically part of the synovial joint and the synovial capsule, they are closely associated. So these serve pretty much the same function, they just have slightly different structures. So your bursae are like the little sacs or ball bearings of synovial fluid that's going to reduce friction where structures like ligaments, muscles, skin, tendons, or bones may rub together. Tendon sheaths are essentially elongated bursae that will wrap completely around a tendon that may be subjected to friction. So kind of the way a hot dog bun wraps around a hot dog. So this is showing how the bursae work during movement at the shoulder joint. So we have our little ball bearing, our little sac of synovial fluid in between the head of the humerus and the acromion of the scapula. So when we move the shoulder outward, or we abduct the shoulder, move this way, this little bursae or this little ball bearing will roll in the opposite direction. So we'll reduce the friction where this bone otherwise would be rubbing against the tendon and the other bone. Then you can see the tendon sheath is essentially the same as a bursae. It's just an elongated sheath that's going to wrap around our tendon and help cushion it as the bone and the joint move. 3 factors can determine the stability of our synovial joints and help prevent them from dislocating. So number 1 is the shape of the articular surface. So how well do the bone ends fit together? So the more shallow your articular surface, like on the knee, the less stable it would be compared to, say, a ball and socket in the hip. So the number and location of ligaments also play a role in our joint stability. So the more ligaments you have, the stronger the joint. So the more points of support and attachment, the more stable that joint will be. Probably the most important factor is muscle tone. So our muscles are always in a slightly contracted state to help keep our tendons tight and taut as they cross and stabilize these joints. So this is important for reinforcing those joints like the shoulder and the knee and the arches of the foot. All muscles will attach to bone or connective tissue at 2 or more points. So the origin is where the muscle attaches to the immovable bone. So every time we use our joint or move a joint, one bone is being moved and one bone is acting kind of as our stable support or our anchoring point. So that would be your origin. So kind of your anchor point that we're going to pull from. Right, so remember, muscles always pull, they never push. The insertion would be the muscle's attachment to the movable bone or the bone that we're trying to move. So your muscle contraction is going to cause the insertion to move closer to the origin. So in this example of the bicep, so bicep is going to originate near the head of the humerus and the scapula, and it's going to insert on the forearm bone, on the radius. So when the bicep contracts, it's going to pull and shorten, and it's going to pull the forearm closer to the origin. Same thing in this example, the calf muscle, the gastrocnemius. So it's going to originate on the back of the femur and then insert on the back of the heel bone. So when this muscle contracts, it's going to pull the heel this way and point the foot downward and essentially decrease the angle between the heel bone and the back of the femur. There's 3 general types of movements we have with synovial joints. We have a gliding movement, angular movements, or rotational movements. In gliding movements, one flat bone will essentially glide or slip over another flat bone surface. So these are commonly found in the intercarpal or the wrist joints and the ankle joints or intertarsals. Angular movements are going to either increase or decrease the angle between 2 bones, between that origin and insertion. These generally have movement along a sagittal plane. And these angular movements include flexion, which decreases the angle of the joint. Extension is going to increase the angle of the joint. And hyperextension, which goes beyond the normal anatomical position. So when we talk about increase or decrease the angle of the joint, so imagine an anatomical position, your arm is straight down at your side, right? So this would be our 180-degree angle. So it's almost straight line, right? Flat. So when you flex your arm, right, you're bringing it up. So now we're closer to a 90-degree angle, right? Maybe like a 120-degree angle here. So we've decreased that angle. If we're going to extend, right, so now we're going to increase the angle of the joint. Other angular movements include abduction, which is movement away from the midline. Right, so if someone's been kidnapped, they've been abducted, they've been taken away. So abduction is moving away from the midline. Adduction is moving toward the midline. So we're bringing the body parts together, we're adding them, right, and bringing them together. So we're moving back toward that midline. Circumduction involves a combination of flexion, abduction, extension, and adduction. So it's essentially moving your limb, your arm, or your leg in small circles. Rotation involves the turning of the bone on its long axis, either toward the midline or away from it. So a medial rotation, we're going toward the midline, right? Lateral rotation would be going away from the midline. The humerus and the femur also have slight degrees of rotation, but the best example would be the vertebrae, so when you can rotate your head on your neck. Some special movements found in certain locations of the body include supination and pronation. So this occurs in the radius and the ulna of the forearm. So supination is when the palms are facing anteriorly. So the palms are in anatomical position facing outward. So in supination, the radius and the ulna of the forearm, the 2 bones, are parallel, so they're right next to one another. In pronation, the palms face posteriorly. So remember, pronation, P, palms posterior pronation. Right. So in pronation, when we turn the palms posteriorly, the radius will rotate over that ulna. So now they're kind of crisscrossed in pronation. Dorsiflexion and plantar flexion occur in the foot. So dorsiflexion is bending the foot toward the shin, lifting the foot upward. Plantar flexion is pointing the toes downward. Inversion and eversion also occur in the foot. So inversion, you're turning the sole of your foot medially toward the midline. Eversion, you're turning the sole of your foot outward laterally. Protraction and retraction occur in the mandible. So protraction is where the mandible or the lower jaw will kind of jut or stick outward. Right? So you have an underbite. Retraction is where the mandible is pulled inward toward the neck or retracted inward. So you would have more of an overbite. Elevation and depression occur in the mandible and the shoulders. So elevation is just lifting up a body part. So when you shrug your shoulders, that's elevation. When you relax your shoulders, that would be depression. So same thing with the mandible when you open and close your mouth. So closing your mouth is elevation. Opening would be depression. Opposition is found in the thumb. So where we have opposable thumbs, it just means that our thumb is able to touch every other fingertip on our hand. So this allows us wide range of motion and dexterity in our grasping abilities. So just to summarize all of our type of synovial joint movements, your gliding movements occur at those flat surfaces of, say, the wrist bones or the ankle bones. Flexion is where we decrease the angle between two bones. So when you flex your bicep, you're bringing those bones closer together. Extension is increasing the angle between the bones. Abduction is movement away from the midline. So abduction is being taken away. Adduction is moving the limb toward the midline. So we're bringing them together. We're adding them back together. Circumduction is moving the arm or leg or finger in small circles so that it describes a cone in space. And rotational movements involve turning a bone on the longitudinal axis. So we could have a medial rotation toward the midline or a lateral rotation away from the midline. There's 6 types of synovial joints based on the shape of their articular surfaces as well as the type of movement capable at that joint. So types of synovial joints we'll look at include the plane joints, which have that gliding movement like in the wrists and the ankles. Hinge joints, like in the elbow. Pivot joint that allows rotation of the head. Condylar joints of the knuckles and the hands. Some saddle joints also found in the hand and knuckle bones. And then ball and socket joints, like your hip and your shoulder. So again, the plane joints have that gliding movement, so like the carpals or the little small flat bones in the wrist. So when you move your wrist side to side, wave your wrist, these bones are just going to kind of glide and slip over and across one another. The hinge joint looks a lot kind of like a door hinge. So we have kind of a cylinder and a trough. So classic example is the elbow. So these hinge joints really only have one direction of movement. So just like a door can only swing open or close. Your elbow can only flex or extend. Pivot joint is essentially a rod in a hole. It's kind of like a tower rod. So this is found in the radio-ulnar joint of the forearm. When we talked about supination and pronation, when you go pronation and turn your palms posteriorly, the radius will pivot and crisscross over the ulna. Condylar joints have these oval articular surfaces, so they're similar to the ball and socket joint, but they don't have as wide a range of movement. So these are found in the knuckle joints or the metacarpopharyngeal or knuckle joints, as well as some of the wrist joints. So these type of joints allow for flexion and extension as well as abduction and adduction. Saddle joint found in the carpometacarpal joint of the thumb, or the knuckle of the thumb, is also going to allow the adduction and abduction as well as flexion and extension. So it has a wide range of movement. Ball and socket joints have the widest range of motion. So it's essentially a cup or a socket with a ball or a head on the end of the bone. So the ball fits in the socket to allow this multi-axial movement. So we have flexion and extension, abduction and adduction, as well as rotation. So example of your ball and socket joints would be the shoulder and the hip. So think of how much movement you can have with your shoulder compared to your wrist or your elbow. So we said there's lots of different types of synovial joints, so they're very diverse and they all have their own unique structural features, abilities, and weaknesses. So 5 of our main synovial joints that we'll look at include the jaw or the temporomandibular or TMJ joint, the shoulder, elbow, hip, and the knee. The temporomandibular joint, or also known as TMJ, is a type of modified hinge joint. So the mandibular condyle, or the end little nub of the jawbone, the mandible, will articulate with the temporal bone on the side of the skull. The articular capsule in this joint thickens into a strong lateral ligament that's going to help support this joint. There's 2 types of movement we see with the jaw or the TMJ. So we have hinge type movement with our depression and elevation. So we just open and close the jaw. We also have a little bit of gliding movement or that side to side motion of, say, grinding of teeth. The jaw joint is the most easily dislocated joint in the body because it has such a relatively tiny joint capsule, very shallow attachment. The shoulder joint, or also known as the glenohumeral joint, is the most freely moving joint in the body. So as with most things, though, there was a trade-off. So in exchange for that increased mobility and freedom of movement, we have sacrificed some of its stability. So the shoulder is also another relatively easily dislocated joint. So it is a ball and socket joint, but it has a fairly shallow joint cavity. So the socket's not very deep. So it's more like a golf ball sitting on a tee. So here's our glenoid cavity, so where the bone's going to articulate, not a very deep socket. The articular capsule around the joint is also fairly thin. This helps contribute to its wide range of movement. And as you can see, there's also several associated bursae and tendon sheaths, as well as tendons and ligaments to help support this joint. The glenoid labrum is a rim of fibrocartilage around that glenoid cavity or that socket, just to add a little bit more depth because it is so shallow. But even still, it's only going to hold about 1/3 of the humeral head. Like I said, there are various reinforcing ligaments, primarily on the anterior aspect of the shoulder, just to add that extra support and stability. Most of our shoulder joint stability comes from these reinforcing muscles and tendons. So there's 4 rotator cuff muscles and tendons that surround the shoulder joint and help stabilize it. The subscapularis, right near the bottom of the scapula, the supraspinatus, so supra meaning above the spine. This is the spine of the scapula, so we have one here above. Infraspinatus, below the spine, and the teres minor, which is the small or the minor strap-like muscle at the bottom. The elbow joint is where the humerus articulates with the radius and ulna of the forearm. So it is a type of hinge joint formed primarily from the trochlear notch of the ulna and the trochlea of the humerus. So the trochlea goes in the trochlear notch. So we said hinge joints only have that one direction of movement, just like a door hinge. A door can only swing open and close. The elbow can only flex and extend. The hip joint or the coxal joint is a ball and socket joint similar to the shoulder, but it has a much deeper socket. So it also has a wide range of motion similar to the shoulder, but it's limited by this deep socket. So just as we had the glenoid labrum in the shoulder joint, we have the acetabular labrum in the hip joint just to help expand the depth of our socket. So because of this ultra deep socket in the hip joint, hip locations are much less common than shoulder locations. The knee joint is the largest and most complex joint in the body because it has to support our entire body weight as well as maintain our balance and walking. So really we could break it down into 3 different joints that share a single joint cavity. So the first joint is the femoropatellar joint. So this is a plain joint that allows for that gliding motion during knee flexion. So where the patella or the kneecap will glide over the femur when the knee extends or flexes. The lateral and medial joints are called the tibiofemoral joints. So this is where the tibia and the fibula join together and then join to the femur. So this is the joint between the femoral condyles and the lateral and medial menisci of the tibia. So remember those fibrocartilage pads just to improve the fit and support stability of the joint. So the knee is classified as a hinge joint, but it does allow some rotation when the knee is partially flexed. So when your leg is straight, your knee's locked, you can only flex and extend. You can't rotate your knee. But if you flex your knee, bend your knee a little bit, then your lower leg, you can rotate a little bit in those small circles. So the joint capsule of the knee joint is basically absent anteriorly. So we have the patella, the kneecap bone, almost directly on top of the end of the femur bone. When we look at the anterior portion of the knee, the quadriceps tendon, so the main muscle in the thigh, this tendon coming off of the quadriceps will then kind of branch off and give rise to 3 broad ligaments to help support the knee. So the medial and lateral patellar retinaculum are going to flank or be side by side of the patellar ligament. Right, so we have a ligament on the lateral side and a ligament on the medial side. And then we have one connecting the patella, the kneecap, to the tibia. So when you go to the doctor and they tap your knee with the hammer to test your reflexes, they're tapping on this patellar ligament. And showing the lateral and medial meniscus to help improve that fit of the bone ends of the femur onto the tibia. The knee also contains several ligaments to help stabilize and support it. So some ligaments found in the capsular and extracapsular region help prevent a hyperextension of the knee. So your fibular and tibial collateral ligaments are going to help prevent the knee from rotating while it's extended. The oblique popliteal ligament is going to stabilize the posterior knee joint. So popliteal is the back of the knee region. Oblique means kind of diagonal. And the arcuate popliteal ligament is going to reinforce the joint capsule posteriorly. So this is looking at the posterior of the joint capsule. Within the joint capsule, we also have intracapsular ligaments to help prevent joint displacement. So the 2 main intracapsular ligaments are your anterior cruciate ligament, or the ACL. Right? So cruciate, think that it's crucial to keeping these bones attached. So it's going to attach to the front or the anterior of the tibia, and it's going to prevent the hyperextension of the knee or the tibia from sliding forward, right? Stretching forward. So this is a common injury in athletes. So see, it's kind of right in the center axis of the knee. So when they're running at high speeds and maybe they change directions too quickly, or they have a lot of twisting forces, it can snap this small ACL ligament. The posterior cruciate ligament is going to be on the posterior side of the tibia and prevent a backward sliding of the tibia or the femur from sliding, buckling forward. A common type of joint injury includes cartilage tears. So these are typically due to some type of compression or shear stress. When the cartilage has been torn or damaged, it can cause a joint to kind of lock up. And because cartilage is avascular, it has a poor nutrient blood supply, it rarely repairs itself. And if it does, it's a very slow healing process. Sprains are when those reinforcing ligaments are stretched or torn. So it's common to occur in like the ankle and the knee, in the back. So just like with the cartilage tears, these connective tissue tears and sprains heal very slowly, if at all, because of that poor vascularization. They don't have their own blood supply. So depending on the severity of the sprain, the ligaments can be sewn back together, but more often than not, it's going to have to take time and some immobilization, so stay off of it for a while and let it heal. Dislocations or luxation is when a bone has been forced out of its normal alignment. So this would typically accompany your sprains or torn ligaments and inflammation and difficulty moving that joint. So dislocations occur by either serious falls or contact sports. So we said our joints are pretty stable with all of their ligaments and supporting tendons and muscles. So it takes a lot of force to force them out of alignment. So to treat dislocations, the bones have to be realigned in their proper place and then reduced to treat. A subluxation is just a partial dislocation of a joint. So like if you go to a chiropractor, they may talk about subluxations where you have things are a little bit out of alignment that they'll pop back in. Bursitis is inflammation of the bursa, or those little ball-bearing, friction-reducing sacs of synovial fluid. So these are typically caused by just overuse, friction, or injury. Tendinitis is inflammation of the tendon sheaths. Remember we said the tendon sheaths were basically just elongated bursae. So again, just caused by overuse and would have similar symptoms to bursitis. Arthritis is a collective term for over 100 different types of inflammatory or degenerative diseases that damage and target the joints. So symptoms include pain, stiffness, and swelling of the joints. Some more acute forms can be caused by bacteria and can be treated, but the chronic forms include osteoarthritis, rheumatoid arthritis, and gouty arthritis. Osteoarthritis is the most common type. It's just your normal kind of wear and tear type of arthritis. So as we age and over the years, lots of use of those joints, things unfortunately just start to break down. So some of the articular cartilage on the ends of the long bones will start to wear away, exposing the bone in. So now the bone on bone friction is occurring. Rheumatoid arthritis is an autoimmune disease where the immune system attacks the cells in joint cavities. Signs and symptoms include joint pain and swelling, anemia, muscle weakness, and possibly cardiovascular problems. The hallmark sign of rheumatoid arthritis is kind of disfigurement and displacement of the joints and the bones. Gouty arthritis is caused by deposition of uric acid crystals between the joints and the soft tissues. The most common place this occurs is at the joint of the big toe. The treatment includes medication, drinking plenty of water, or just avoiding foods that have high uric acid to begin with. Lyme disease is actually caused by a bacteria that's transmitted through tick bites. So one of the symptoms of Lyme disease is joint pain and arthritis, so hot, swollen, painful joints. The treatment for Lyme disease includes a long course of antibiotics.